All right, time to discuss Cox technique for the scoliotic patient. Scoliosis is defined as a lateral curvature of the spine that's greater than 10 degrees. Mild would be 10 to 25, moderate 26 to 40, severe greater than 40. Three major types of scoliosis exist. Congenital is where you're born with a misshaped vertebrae, where the spine is forced to alter its lateral deviation to compensate for that maybe trapezoid shaped vertebrae. Idiopathic is the more common. The idiopathic adolescent scoliosis is truly that. It's idiopathic. There really has not been any discovery yet as to why that does occur. It is about 70 to 80% more prevalent in females than males. And then neuromuscular would be some type of neurodegenerative disorder like muscular dystrophy or cerebral palsy, where there's just tremendous muscular imbalance. Idiopathic scoliosis is divided into three subcategories based on the age of onset. So you have your infantile idiopathic scoliosis. That affects patients younger than 3 years. I've only had one of those, and a mother, that trusted patient and new mother, brought the child to me, and she said, Dr. Garber, something just seems off. And yeah, when I examined and looked at the child, it was very apparent that the child was born with an idiopathic scoliosis. Juvenile idiopathic scoliosis particularly appears in around the pubescent years, but it can occur anywhere between 3 and 10 years of age. And then adolescent idiopathic scoliosis occurs in skeletally immature patients that are older than 10, typically when the hormones begin to kick in and the secondary growth centers begin to start. So, no research is available for the Cox flexion distraction procedures pertaining to the scoliotic patient. So everything we share with you is basically anecdotal, but we feel like the technique is mechanically correct and has the potential to possibly either minimize or reduce scoliotic curvature. But what you'll find is that we also have treatment protocols for patients with a scoliosis who come in with a disc or disorder or a non-disc disorder and are just really looking for relief of their pain. The procedures are easy to use, and we know from prior research that we can restore physiologic range of movement to facets and just increase range of movement in general throughout the spine. And with the scoliotic curvature, you're always going to have a reduction in range of movement, particularly in lateral bending and rotation when you try and laterally bend and rotate into the side of the convexity. All right, so there's three applications for Cox technique in the scoliotic patient, and they all have their own little caveat associated with them. Number one is a patient who presents to your office with a disc disorder with a radicular lesion, obviously placing them into a Protocol 1 presentation. And upon x-ray, you notice that they have a scoliosis. So let's say this is their x-ray. And so you can see the lumbar spine lateral curvature goes to the left. That is known as a levoscoliosis. And then the thoracic lateral curvature goes to the right. That's a dextroscoliosis. So the main issue with a disc-related lesion and a scoliotic curve is the vertebral end plates are all askewed. And so through using the lateral flexion component of the table, you have to try and level off or balance the end plates before you actually decompress the involved disc. And that's going to be more clear in the instructional video, which is right after this video here. Number 2 is the scoliotic patient with a non-disc or non-radicular lesion, basically someone who's just come to you for painful disorder of their spine, and you've chose to use coxflexion decompression on them. The caveat here is, if you recall, with protocol 2, we do lateral flexion and circumduction both to the left and the right. So in the case of a scoliosis, you're not going to do the lateral flexion to the right side, nor will you do the circumduction to the right side. And again, we're going to clarify that with the instructional video, which comes after this one. Number 3 is the general scoliotic patient, maybe an adolescent who's been examined by a nurse at a middle or junior high school, and they've discovered that there is some type of imbalance, and the child is brought to your office. You notice the imbalance as well and x-ray the child, and this will just say, again, this is their x-ray right there. And the mother, who is a trusting patient, is going to inquire as to whether or not you might be able to assist with either reducing or correcting the scoliosis. And unfortunately, we don't have any research in that area. We don't even have any case studies on the website, whereas for the Protocol 1 presentation and the Protocol 2 presentation, we do have clinical case studies showing effectiveness with those conditions. So with scoliosis, all you can do is a clinical trial basis of seeing the child on a regular format and doing Protocol 2 on a global level, where you'd be actually decompressing each segment in the levoscoliosis and then each segment in the dextroscoliosis, and then re-x-raying in either 3 or 6 months to see if there's at least stabilization, if not reduction, of the spinal curvatures. Nonetheless, this is an area that definitely needs more research in order to present it in a specific or more professional fashion. Alrighty. All right, and so there's the 3 protocols, kind of a little narrative on those, and that's something that you can look over on your own. We're going to discuss these in much greater detail during the instructional video. So let's head on over there now.